Welcome to RhAPPcast, the official podcast of rheumatology advanced practice providers. I'm Amanda Mixon, and you've made it to the fifth and final episode of our GCA Fireside Chat series. If you've been with us since the beginning, thanks so much for listening. But if you're just tuning in now, you are in for a great discussion. In today's episode, we're going to dive straight into the risk-benefit dialogue that's top of mind for many providers. With Upadacitinib gaining FDA approval for the treatment of giant cell arteritis, it's critical to understand the safety data, especially in the context of an older, potentially high-risk patient population. Luckily, my guests today need no introduction because you've already met them in episode number 3. That's right. Naomi Amudala, nurse practitioner, and Jessica Farrell, PharmD, are back with us, which means we can skip the intros and get right into the good stuff. We'll take a closer look at the safety outcomes from SELECT-GCA study, including MACE, infection risk, and how to stratify patients appropriately so that you feel good about starting patients, you have the confidence, and the ability to make an informed treatment discussion. So here we go. I'm going to just go ahead and start with Jessica. So let's talk a little bit about the baseline characteristics of the SELECT-GCA participants. So what did these patients look like that enrolled in SELECT-GCA, particularly regarding their age and cardiovascular risk factors?
Yeah, so the population was what we would expect of a GCA patient population. So the one thing regarding age is that these are older patients. So GCA doesn't really affect anyone under 50. So all these patients were certainly above 50. There were about 15% and 17% in different groups that were, under 65. So it's definitely an older population. There was upwards towards 30% of the patient population that was older than 75. So, we've got an older population. So that's good. We want to, this is the patient population that's affected by GCA. So that makes sense. In terms of cardiovascular risk factors, GCA primarily affects females. So there were certainly a lot more females than males. So there were about 74.5% female population. So from a cardiovascular risk, they make it into a little bit lower risk factor. But over about 80% of the patients in all of the treatment groups had some type of cardiovascular risk factor at baseline. So either history of a cardiovascular event. So about 20 to 30% of those patients across placebo and upadacitinib treatment groups, about 30%, maybe 25 to 30% of patients had some kind of history or actually a little bit more of diabetes. So there was 7% in the placebo group. There was 9 and 11% in the different upadacitinib groups. There's also a good portion of patients that had history of hypertension. So almost 50% in each of the treatment groups had hypertension. In terms of other cardiovascular risk factors like smoking status, so there was about 30% that were former smokers and only ranging from 7 to 15% that were current smokers. So that was a smaller population. That's good because we don't want people to be smoking. And then about 60-ish% across the treatment groups were never smoked. And then in terms of cholesterol levels, the data that's provided in the supplement really only looks at low HDLs. So there's no patients really in the placebo or the 7.5 group that had low HDLs, and just one patient in the 15 milligram upadacitinib group. So I like seeing this because I think it gives us a good realistic picture of what our patient population is that and from a cardiovascular risk. So, if they have these baseline characteristics, is the drug going to affect their cardiovascular event rates? So
I think this is super interesting because, again, I think obviously all of us do have a sense of pause when we think of the JAK inhibitors because again, we know the data and we know, kind of potentially who might be at a higher risk. And the other piece of this is you can't so much compare like an RA population with a GCA population because they tend to look very different. So having this information, I think, will be helpful just in terms of overall when I think about prescribing a JAK inhibitor. Naomi, do you agree?
I do. And I have the same fears as you, Amanda. So when it comes to treating patients, especially older patients, I was more hesitant to put them on a JAK inhibitor. But actually, after reviewing all this safety data from the trial, I feel a lot more comfortable putting them on it. The one thing I think just one other thing to add is when you look at the exclusion criteria for the trial, patients who had recent cardiovascular events within the past 6 months were excluded from the study. So, stroke, MI, stenting, different things like that, those patients were not eligible. And so I don't know how that translates into real world practice, but it is something that I think we should be mindful of and maybe think about asking our patients as just part of the history before starting them on UPA.
Absolutely. And I mean, I guess from that perspective, 60 milligrams of prednisone as well, in terms of thinking about if they've just had some major cardiovascular event, I would definitely be calling their cardiologist to say, hey, this is happening, because obviously we need to preserve their vision, but also we have to kind of take all of these things into consideration. So, Jessica, can you talk a little bit about what the actual major adverse cardiovascular events or MACE were observed in the SELECT-GCA study, and how do these findings compare to previous JAK inhibitor trials in other populations?
That is a great question. So, along the lines of your comment about the prednisone, so in this trial, so over 52 weeks, so we've got, it's not like a short trial, but it's not super long either. But in both of the upadacitinib groups, so the 7.5 and the 15 milligram groups, there were no major cardiovascular events. And there were actually some that were seen in the placebo group. So these, again, emphasizing that prednisone is, a risk factor too. So we need to keep that in mind, especially when we are thinking of prescribing these drugs. Steroids are a given, they're going to get steroids. So it is important to recognize that, those steroids have risk too. So, and if potentially bigger risk. So that was the major cardiovascular events. There were some VTEs that were seen. So across the treatment groups, it was pretty even, about 3%. So, these are I think for a GCA study, this is a pretty big study. So there is a little over 100 patients in the placebo group, 100 in the 7.5 group, and then over 200 in the 15 milligram group. So to have like a consistent, percentage happening in all three groups, that again gives me confidence that, okay, like this is happening in all three and there's not a difference there. So that's helpful. Your other question was related to events seen in other clinical trials. So I think this is tough to compare. So when the other clinical trials are in an RA population, so that is a different population. So I think there's Select Next, Select Compare. So those are some of the RA studies that look at UPA and look at safety. And in those studies, there were some events, but the rates were about 0.4 per 100 patient years. So to me, that's a really low number. And it was comparable to, in the studies that had the adalimumab treatment arm, comparable to a TNF. There was a meta-analysis of all of the RA studies that were done that was published in Current Reviews of Rheumatology in 2024 that did look at the odds ratio of cardiovascular events for UPA. And that was about an odds ratio of 1.2, but it had a really wide confidence interval. So it was not statistically significant. So I think that as we're getting, further post-marketing and further data, longer-term data with upadacitinib, that we are getting more comfortable that we're seeing consistency across studies and different types of populations. So this is, again, just another piece of information that gives me confidence that, yes, we need to be screening these patients, but, I can tell my patient that, based on the current clinical trial data, it does not seem that this is really going to have a major effect on their cardiovascular risk. And compared to steroids, and just using that comparison again, that how many side effects there are to prednisone, not just cardiovascular risks, diabetes, infections, and just the list goes on, osteoporosis. So I think, looking at the nitty-gritty safety data really does help me just be more confident delivering that message to my patient population. So
you kind of alluded to this a little bit, but what about infections, malignancies? What did the SELECT-GCA trial show there?
Yeah. So when I think of infections with steroids, I think of all types of infections. So there certainly were infections. There are actually about 10% of infections happened in the placebo group, and that is more than in the UPA group for serious infections. So again, emphasizing the safety concerns with prednisone. There were some opportunistic infections. So there are a couple more in the UPA 15 milligram group. There weren't any in the 7.5, and there was one in the placebo group. So a couple more in the UPA group. I do get concerned with zoster, which we've talked about this before. So in the 15 milligram group, there were definitely some cases of zoster, so at a rate of about 5%. And then the prednisone group, there was about a rate of 2% to 2 or 3%. So we talked about this before, vaccinating our patients, making sure that if they're vaccinated before, in this disease state, it's a little bit challenging because we're concerned with vaccine response with the high doses of prednisone. But, just in general, I think that from a primary care perspective, Shingrix vaccination is on the checklist. So hopefully these patients are getting their regular health maintenance, and by the time they present to us, hopefully then vaccinated, especially given their age group, because most patients without an autoimmune disease at the age of 50 can get vaccinated. So this is a certainly older population. So hopefully they have been vaccinated. And then I think you mentioned malignancies. So, malignancies is tough because this is a 52-week study. So I don't really put much weight on that. There were some cancers that were found in the placebo group. So I think 2 different cancers in the placebo group, 4 in the upadacitinib 15 milligram group. Again, it's a 52-week study. Do I think that either of these treatments played a role on their cancer risk in this time frame? Probably not. And then non-melanoma skin cancers, there were a handful in the UPA 15 group, so I think 4 or 5, and then 2 in the placebo group. So again, I think looking at malignancy data in a short study is not, I'm happy that the authors report it and that they looked at it when they were doing the trial, but to me, that doesn't really tell us too much. But the rates in other studies are pretty consistent. So, yeah.
Well, and too, we're talking about older people, and unfortunately, older people also do get cancer. And so we just kind of have to think about that when we're risk stratifying these patients as well. And that's going to kind of lead me to my next question, which thank you, Jessica, for really talking about that. And, again, from that perspective, I feel like what I'm hearing is, steroids bad, and there's lots of stuff that can happen to you on high doses of steroids, which we all know. And actually, upadacitinib is a much better option than having patients on, long-term chronic high doses of steroids, which I'm sure is not shocking to any of the listeners here. But also too, it kind of makes me think maybe all JAKs, and we've kind of talked about this in other areas, that maybe all JAKs are not alike. And so maybe you can't really compare all of them in terms of looking at all the risks. So Naomi, so we've just laid this all out for us. How do you feel like this influences your willingness to use a JAK inhibitor in patients with GCA?
I wish, Jess, I had you in my clinic with me so that you could present all this data every time I'm talking to a patient about starting a JAK inhibitor. It's so helpful to have you go over all of that. And as I said before, I feel a lot better about starting patients, specifically GCA patients, on a JAK inhibitor. And we're talking about patients who are typically elderly and have other comorbidities. So this is not your young 20-something-year-old who you're starting UPA on because they have RA. And I think you've both mentioned this, but it's a very different population. And I think, and I appreciate that you mentioned this, is that we can't underestimate how important it is to put patients on medications that are steroid sparing, because otherwise patients who are on prednisone long term, as you know, there's just so many toxicities associated with it. And when I was looking in the trial data, it was interesting to see that patients who were in the placebo group were exposed to almost double the amount of corticosteroids compared to patients in the UPA group. And so that is very significant and really, like, on a day-to-day basis has a big impact on patients' lives, just in terms of risk of infection, osteoporosis, diabetes, hypertension, bruising, infection, wound healing, you name it, and prednisone, I think, can impact it. So all that to say, what do I think about when I'm starting a patient on a JAK inhibitor, if they would be a good candidate for that drug? First of all, I think we're looking at their past medical history. Do they have any kind of glaring comorbidities that I would not feel comfortable putting them on that JAK? And I do think specifically about MACE, and have they ever had a history of a blood clot? There was one patient that we were considering putting on UPA recently, and she did have a history of blood clot. And so we didn't feel comfortable putting her on that drug. And I know in the past as well, one reason why I haven't put a patient on UPA is because they don't want to get the shingles vaccine. And so I have that discussion with them, and it is shared patient decision making. So if they don't want to get the shingles vaccine, that's within their right. But then often when I present the data to them, they do not feel comfortable kind of proceeding with a JAK inhibitor. So those are kind of the two big things that I look at when thinking about a good candidate for the medication. I think the ability for compliance in checking labs on a regular basis as well, that's important. Some patients just disappear after you want a drug. And so I just don't feel as comfortable with. Well, really with any drug, but those are the big things. I think in the study, if they had a history of certain malignancies, if they were wheelchair bound, if they had a history of a GI perforation, they were excluded from the trial. Again, I'm not sure how that really plays out in day-to-day life, but I do think it's interesting. And I think the fact that patients who were in a wheelchair or bedbound were excluded from the study maybe speaks to that risk of clots. And so it's just something to take into consideration when you're talking to your patients.
Absolutely. And I feel like, again, I totally agree with you. This was exactly what I would do too. And again, at least at this point, I would not feel comfortable if a patient had a history of a blood clot, especially because we do have another option, right, for patients, which again, just goes to the fact that it's so lovely that we do have other steroid-sparing options. However, I think we both have this confidence of prescribing upadacitinib for our GCA patients, because if we do look at this data, like, again, high doses of steroids, the risks are so much worse, as, Jessica talked about. And so I feel like, again, I have a lot more confidence when I think about, these patients, just kind of looking at this data. But also, to your point, Naomi, we still need to understand who our patients are and who may not be appropriate for it. So I'm just going to kind of then go into a question for you, Naomi, and then I would also very much appreciate Jessa's opinion on this. If you do choose upadacitinib for patients, what are you doing? How are you monitoring strategies or risk mitigation steps to ensure, proper safety for our patients?
Well, it's like any other immunosuppressive drug that you start your patients on, right? So you're educating the patient, you are reviewing medication side effects, you're reviewing why we get labs checked. I always think it's important for patients to understand the why behind things, not just that we're kind of issuing these edicts for them, but they need to understand the rationale behind it. And then it's routine lab monitoring. And if you have the capacity or the ability to check in with them, I always like to check in with the patients, even if it's just a quick phone call 4 to 6 weeks later, to make sure that they are taking the medication correctly and that they don't have any side effects. But other than that, maybe you would keep a closer eye out for those cardiovascular events, just keeping in mind the class of medication. But beyond that, I don't think I would do anything that I wouldn't do for any other drug. I don't know, Jess, what do you think?
Yeah, and we've talked about this before, like me being part of the team, it gives our providers the luxury of having me do some of the counseling and the follow-up, so that saves them time. So I'm able to check in on the patient. My team helps follow prednisone tapers. So that's one we didn't really talk about. But these patients are older, so like sometimes they get confused with their prednisone taper, and then they've got like all these different strengths of prednisone at home, and they, sometimes forget like, oh, don't keep tapering if I'm having symptoms and that kind of stuff. So I have a team of residents and students that will call and check in on patients. So we have that luxury here. And one of the other things I'll sometimes check into, obviously if they're a smoker, that's something to take in consideration in smoking cessation, but like healthy lifestyle habits. So asking them about whether they're, walking daily and if they're able to take a walk or have, if they're able, if they have joint disease, is there a gym that they can join, that they can use the pool. And I have patients that do Zumba and, but modified. And I have patients that do water aerobics and things like that. So I offer up some of those suggestions if they're willing to, and that can also help lower their cardiovascular risk. And then, sometimes asking about diet too. But for you guys, I know it's, you're so limited in time when you have with a patient. So if you can have some support staff assist with some of those things or even handouts in clinic, that can help save you a little bit of time too. But those are one of the things I would add in.
Wow. Well, that is just so helpful. And I think I definitely can speak for myself, but also probably most of our listeners, that we really wish that Naomi would be with us to diagnose vasculitis and that Jess would be with us to help determine the treatment plan and then actually oversee that treatment plan. So that would be my dream, I think, in my clinic. But again, I feel so fortunate that both of you were here to discuss this safety conversation. So again, thank you so much. That brings us to an end. And hopefully, again, you as the listener feel more confident understanding the data. And I know it can be challenging when you're reviewing clinical trials. I struggle reading clinical trials, journals, all of those things. So just to have someone break these things down, I think can be super helpful and make it more real world. This episode wraps up our GCA Fireside Chat series, but if you missed any of the earlier conversation, now is the time to catch up. From diagnostic red flags to treatment strategies and clinical trial deep dives, each episode offers expert insights to help you elevate your approach to managing patients with GCA. We've had some amazing experts on this series. You can find the entire series and all of RhAPP's digital education on the content room at rhapp.org or on our RhAPP ACE 2.0 mobile app or on your favorite podcast app. And to stay in the loop, follow us on social media at RhAPP on X and Instagram and Rheumatology Advanced Practice Providers on LinkedIn. Thank you to AbbVie for their continued support of APP education. Thank you so much to all of our listeners for joining us on RhAPPcast. I'm Amanda Mixon, signing off.